Good morning, everybody. Disclosure that I have a research agreement with Philips Healthcare and Ultrasound. So ultrasound has been a ubiquitous tool in medicine for many, many years, if not decades, and I'm sure many of you order ultrasounds for many indications in many of your patients, whether it be abdominal pelvic pain in patients with suspected renal disease or those with suspected thyroid problems or enlarged lymph nodes. And why is ultrasound used so commonly? Well, it has relatively low cost. It's safe, particularly in your young patients and pregnant patients. There's a high patient acceptance. There's no radiation risk or concern for need for sedation. It's widely available and it has a high negative predictive value for many indications. And of course, these are all the goals of many screening tests used in medicine. One example of ultrasound's use in screening and surveillance is in abdominal aortic aneurysm. And the goal is to identify those patients at risk, to identify aneurysms and look at the rate of growth to capture those patients before they rupture. And the American College of Radiology, the ACR, has listed ultrasound as the top preferred test in screening at-risk patients and following those patients up prospectively. And so that shows how ultrasound can be used in targeted patient populations to provide very cost-conscious care. But I'm not here to talk about the old tricks, I'm here to talk about some of the new tricks. So you've already heard some of the advances in CT and MRI, and ultrasound has also benefited from significant advancements in image quality and also the development of new ultrasound techniques, two of which I wish to talk to you today about briefly. One is shear wave elastography, and another is contrast-enhanced ultrasound. And to do that, I'm going to talk about patients with chronic liver disease. Chronic liver disease is obviously a very common problem here in the United States and worldwide. Hepatitis C gets a lot of attention in the media, especially with all the commercials for all the expensive drugs that are out there now. But in reality, fatty liver disease and steatohepatitis is becoming an ever greater worry here in the United States. And as of 2012, the CDC actually said that steatohepatitis is now the leading cause of new cases of chronic liver disease and cirrhosis here in the United States, surpassing hepatitis C. So the next 10 years, you're not going to hear about hepatitis C anymore. It's going to be patients with fatty liver. And why do we worry about chronic liver disease? Well, the morbidity and mortality of patients just with chronic liver disease is significant, with a significant number of deaths each year just due to cirrhosis. However, those patients are obviously at risk for hepatocellular carcinoma. HCC overall has a pretty poor 5-year survival rate unless it's caught early. If caught early, the 5-year survival rate is actually pretty good. So therefore, a very robust screening and surveillance program is needed in these at-risk patients. I've already talked about the benefits of ultrasound in a patient population such as this. It's safe, inexpensive, and widely available. But you do hear about some drawbacks. It's technologist dependent, has variable performance, and there's discrepant reports in the literature of ultrasound sensitivity and specificity for detecting HCC. And why is that? Well, I implore you to consider the quality of the ultrasound exams and the reports that you may be receiving. What's the age of the technology being used? How rigorous is the tech training program? Is there a quality control program in place? These are all necessities for high-quality ultrasound. And for the radiologist interpreting those examinations, is there a standardized reporting protocol? Are they providing you with follow-up recommendations when something is of concern on the test? So these images show some of the image quality improvements that we've benefited from in the last 5 years. But it's not just the image quality that we need to worry about, it's also the protocol. So is the hepatic parenchyma in the liver capsule assessed? Is there assessment for ascites? And is the spleen image to look for spleen size and splenomegaly? Because these are also other indicators of patients at risk of their development of portal hypertension and decompensation. So this brings me then to one of the new tools in ultrasound, and that's ultrasound elastography. In patients with chronic liver disease, the gold standard assessment is still biopsy. And when you do a core needle biopsy of a liver, the pathologist will give you a report with two major assessments, the inflammatory grade and the fibrosis stage. And the fibrosis stage is the key feature for determining the severity of the liver disease in that patient. And the worsening of the fibrosis, the progression of fibrosis, is the key indicator of long-term outcomes in that patient. The faster they're developing the fibrosis, the sooner they're going to end up with cirrhosis and need a liver transplant. So in comes ultrasound elastography, or stiffness imaging, also known in some papers as sonoelastography. And it's a measurement of the degree of tissue distortion in response to an externally applied force, or a sophisticated way of saying it's the imaging of the stiffness of a tissue. And in radiology, we've used it to look at many different organs and tissues in the body, but today I'll be talking about the liver. There are several different kinds of elastography in ultrasound. The first one developed was called strain elastography. It was a freehand technique where there was actually a manually applied force with the ultrasound probe, and the ultrasound machine then detected the displacement of the tissues deep to the probe and provided a color map representation of the relative stiffness of one part of the tissue to another. It's useful in breast imaging and in thyroid imaging and lymph node imaging. It's not so much used in the liver as it's a qualitative assessment, not a quantitative assessment. There is one technique called transient elastography, or FibroScan. This is a point-of-care non-imaging device that's primarily marketed to hepatologists as an in-office test. It uses mechanical waves to create these shear waves in the liver to determine its stiffness. It has some advantages, however. It's a relatively expensive device. It still has operator dependence. There is significant measurement variability and a high rate of failure reported in the literature, primarily in patients who are obese and patients with ascites. And of course, obesity is not a problem here, of course. The latest technology is called shear wave elastography. And instead of applying a manual push with the probe, you actually allow the ultrasound device to send in a very high amplitude push pulse. It can be developed on it can be employed on a standard ultrasound machine with a standard ultrasound probe, and within a region of interest, we send in these very high amplitude push pulses. Those high amplitude push pulses cause shear waves that transmit laterally from the push pulse, and in this little region of interest, we can measure the speed with which those shear waves travel through the tissue. Stiffer tissues mean that those shear waves pass faster through the tissue. More elastic or softer tissues allow those shear waves to pass slower. So the measurement of the speed of those shear waves gives us a measurement of the stiffness. So this is how it looks on our ultrasound devices, this little region of interest here placed in the liver, and it gives us a readout of the shear wave velocity. And then all vendors then give us a cheat sheet that allows us to translate those velocities into a stiffness, or in kilopascals, but more importantly, a level of fibrosis from normal all the way to severe, or cirrhosis. And the new kid on the block is called 2D shear wave imaging. This is almost a color Doppler representation of stiffness. It allows us to measure a larger area of the liver, and it gives us kind of a roadmap of where there are higher or lower areas of fibrosis. And this is actually being rolled out UT Southwestern as we speak. So the benefits and implications are obvious. This is a rapid, non-invasive method for screening at-risk patients for fibrosis and cirrhosis. It can be performed on a standard ultrasound machine, given a few software upgrades. And it can, in many patients, replace biopsy. And I can tell you, UT Southwestern, we provide almost no liver biopsies anymore because we have this technology to screen those patients, and it's even used by insurance companies at UT Southwestern to allow patients to qualify, those with hepatitis C, to qualify for those very expensive medications. This brings me to my last topic I'd like to talk to you today about, and that's contrast-enhanced ultrasound. Since this is a relatively new topic for probably many of you, I'm going to spend a minute talking about the agent itself, because there's obviously a lot of concerns in some patients with gadolinium-based agents and iodinated-based agents for MRI and CT respectively. So I want to talk to you about this agent. In ultrasound, we use microbubbles. These tiny little gas-filled particles are about the size of red blood cells, about 5 microns in size, and they're a gas core that are covered with a lipid shell, okay? And the ultrasound device is exquisitely sensitive to these microbubbles, to the point where we can detect a single bubble, a single 5-micron bubble in the bloodstream, as shown here in this little video. This is an in vitro study. In this micropipette, you can see individual bubbles going back and forth in this micropipette. This allows us to inject minuscule doses of contrast. So unlike in CT, where you may have to administer up to 150 milliliters of contrast, or an MRI, where you're administering up to 20 milliliters, in ultrasound we get away with tenths of milliliters of contrast in order to obtain our images. The other benefit of contrast-enhanced ultrasound is that the agent stays intravascular. So unlike iodinated agents or gadolinium-based agents that leak out into the interstitial space from the capillaries, the microbubbles stay within the capillaries themselves. So they don't leak out, they don't stick around for long periods of time, and they wash out from the body within about 10 minutes after injection. And so this brings me to this slide, which I think is probably the takeaway slide for this part of the discussion, and that's the high safety profile of contrast-enhanced ultrasound. Not only is it cleared quickly from the body, but it's cleared from the lungs. If the patient is breathing, they're going to clear this agent within 10 minutes. So it can be given in any level of renal dysfunction, acute kidney injury, chronic kidney disease, or dialysis. There's a very low reaction rate. There's no cross-reaction rate. If a patient has a reaction to iodinated contrast, they can still get this contrast agent. And there's very few, if any, contraindications. You may have heard some black box warnings placed on these agents several years ago by the FDA. All of those have been lifted due to recent safety studies. So this is what the image itself looks like. This contrast-enhanced ultrasound image usually is shown as a sepia tone. And here you can see this hyper-enhancing nodule in the periphery of the liver, which is barely seen on the grayscale image. And if you don't believe me that there's something there, there's the corresponding MRI, this hyper-enhancing nodule in the periphery of the liver. So contrast-enhanced ultrasound can also be used to characterize lesions. So here in this liver with this patient with cirrhosis, there's this hyper-enhancing nodule with an enhancing pseudocapsule, and it shows washout. These are defining features of hepatocellular carcinoma in CT and in MRI, and they are equally diagnostic in contrast-enhanced ultrasound. I'm going to finish up by showing a few cases of contrast-enhanced ultrasound. This is a 64-year-old female with cirrhosis and a hypervascular lesion seen on a CT. And there it is. But because of an episode of acute kidney injury, she could not undergo another examination with CT or MRI with contrast. So we brought her to ultrasound. Here's that nodule in ultrasound, this hyperechoic subcapsular nodule with blood flow. Here are these small echogenic kidneys, so actually she probably had an element of chronic kidney disease, so acute on chronic insult. And on the contrast-enhanced image, you see this peripheral enhancing nodule. And on real-time imaging, and this is one of the great powers of contrast-enhanced ultrasound, is we can watch this fill in real time. Fills in from the outside in with peripheral nodules of enhancement, and that is characteristic for a hemangioma, and that is a benign finding. So this patient does not have HCC, as they suspected based on the CT, and she could go on her way. You could also see that we're filming in real time with a patient free breathing. So for patients who are short of breath, who can't hold their breath for a CT or MRI, this is a very powerful tool. Here's another HCC in a 68-year-old female with hepatitis C and cirrhosis. She had a prior ablation for an old HCC, and that's the ablation site there. But one of our astute technologists found this hypoechoic nodule adjacent to the zone of ablation. We were worried about recurrent HCC, but again, she had kidney disease, and they did not want to give iodinated or gadolinium-based agents. So with contrast-enhanced ultrasound, we see this hyper-enhancing nodule, and you'll see on the video here this hyper-enhancing nodule as this little old lady is free breathing, hyper-enhancing, and then quickly washes out. Again, features of HCC. She went on to another ablation, and she is now cured. Here's a 79-year-old female with chronic kidney disease, but instead of looking at the liver, we're now looking at the kidneys. And while looking at the kidneys, we found this cyst. And on one of these images, we saw this mural nodule. And if you listen to or you read literature about cysts with mural nodules, you worry about a cancer. Well, again, she couldn't get CT or MRI contrast, so we did contrast-enhanced ultrasound, showing that there's no flow in that nodule, so it's probably some inspissated clot or protein, benign cyst. She could go on her way. My final case is a 45-year-old female with chronic kidney disease after a renal transplant. And on the native kidneys, where they're both atrophic, you see these little nodules here. And we couldn't give contrast. The non-contrast MRI was equally suspicious, but not definitive. But the contrast-enhanced ultrasound shows an enhancing nodule consistent with renal cell carcinoma. So the uses are obvious, not only for kidney and liver characterization, but also performing vascular ultrasound for procedure guidance, and it's also FDA approved for use in pediatric populations. So I hope you realize that there's been recent advances in ultrasound, and ultrasound should be considered as your go-to first-line agent for many indications for your patients as a rule-out test. But it also helps in defining liver disease with the advent of elastography, and as a modality that can be used with contrast now in patients with, who cannot undergo CT or MRI with contrast, or even when CT or MRI was indeterminate. Thank you very much.